Mm. let me. Let me. Hey. Hey, Warlick. I can see you, Warlick. Can you hear me?
Yes, I can hear you.
Oh man, I don't know. I'm so excited you're here.
Yeah, but I have
Well,
to.
more than Dr. Leo.
Yeah, but I have to eat something first. So
Oh, okay, let me.
start from there.
Yeah, let's put it on camera.
What? Eat food, nah? Okay.
We'll
I
put it
have
live,
to.
live on
Yeah,
YouTube. Live on YouTube.
live on YouTube. No. Okay. I gotta take some Grab first.
Oh, this is great. You can hear me, right?
Yes,
Okay,
I can hear you.
yeah, I'm just gonna do some stuff like promoting. Okay. Yeah, you're great on the net, man, on those videos. They're great. With the music. Okay, I'll shut up.
Hello.
Greetings, Zanab. How you doing?
Fine, thank you, sir. Good morning.
Good morning.
How are you,
Good to
sir?
have you here.
Thank you, sir.
And we have Warlicks here too. This is a special occasion.
Yes, sir.
Mahmood, are you there? You want to check in?
Yes. Good morning. Good morning.
Good morning. How are you, Mahmood?
Fine. I'm fine.
Where are you from, Mahmood?
I'm from Nigeria. A
Where?
resident in Nigeria.
Where?
Nigeria.
Oh,
That's a
Nigeria.
brother of mine.
welcome. Well, that's great. Zanab is from Africa too.
We're all from
Yeah.
West Africa.
Yeah.
Sir Mahmood. It's Mahmood, right?
Yes.
Sir, how are you?
Fine. I'm fine.
I'm just from. I have so many Nigerian friends here. I'm just from church with them.
Okay.
Mhm.
That's great. So you're from where?
Originally from the Gambia. It's also in West Africa.
Oh. Okay. Okay. Nice to meet you.
It's a pleasure, sir.
Good morning, James.
Good morning, John. How are you?
Good. Warlick's, are you here? Warlick's is gonna moderate.
Oh,
So
Luis.
she's gonna introduce you. You met her before, right?
I'm sorry, who?
Warlick's, the Thai
Oh, yes.
neurosurgeon, the
Yes.
artist.
Yes, I remember. Yes.
Okay, Warlick's, are you there? Oh, she'll be along. So, how's everything with you?
Oh, fine. Fine. It's been busy.
Oh, good. Here's Warlick's. She's our ace coworker who doesn't know how to mute.
Yeah, I just finished my surgery and I just come back home, and then because I promised to John that I'm going to moderate, so I just have very quick meal. Okay, so I got it like 5 minutes.
Well,
Okay,
I'll
sorry,
tell you why.
sorry.
I'll tell you why, James, because she ate on camera once, and I said, "Warwick, you don't do that."
Am I allowed to take a
Sorry.
sip of coffee?
Oh
on
yeah,
camera?
I mean that's
Sure.
but you don't expect people to be eating on camera.
Right. Zoom etiquette.
Yeah.
Give me a second here. I just got to find my talk and
Okay. You got any your videos are all set and everything?
yeah. Give me a second here while I look for it.
Okay. Yeah, we got time. We got plenty of time. We got 10 minutes. Wan Lee, are you in? I think you met him before. Wan Lee, are you there? He may have stepped away. So Warlock, you're gonna Wan Lee, good day. Warlock's for the cat. Hey, Warlock, this is Wan Lee. Wan Lee, this is Warlock. She's going to let's see. I guess you'll be introducing Ben Zhu,
Hello.
okay?
Okay,
Okay,
sure.
Warlock. You're gonna introduce Ben Zhu, and Ben Zhu is going to introduce James. Okay? Warlock, you're muted.
Okay.
Hi. So today, Dr. Bin and Dr. May I ask for how to pronounce your name correctly? Yuan Lee, right?
Yeah, Wan Lee is going to
Wan
Yes,
Lee.
yes, certainly. Yeah.
Okay.
Yeah, Warwick, you're just gonna introduce Dr. Ben, okay? And he will introduce
Okay.
James, because he's a neurosurgeon. Okay,
Sure.
if Ben comes in here. Let me check. Good day, Dr. Long.
Hello, can
Welcome.
you hear me
Wel-
and see me?
Welcome. Yes, we can see you and we can hear you.
Okay, good.
Okay, well, let me check with Ben. Wan Lee, have you talked to Dr. Ben lately?
Yeah, actually, I can call.
Yeah, could you get call Dr. Ben? Yeah,
Let me find him.
okay.
Anyway, yeah.
Give me one moment, John. I just have to
Yeah,
step away.
sure. Yeah. Yeah, we're gonna hold on for Dr. Bin.
John, can I just test my screen here real quick before we
Yeah,
start?
yeah, go ahead.
How's the video transmitting?
Yeah, that looks good.
Okay.
There's no sound to it. There's no sound to it, right?
No, no. Sound.
Nice video. Huh?
Everything playing okay on your end?
Yeah, it looks good.
Okay, terrific.
Yeah, great quality stuff. Quality video.
Thank you. Good morning to my friends and colleagues in China, Dr. Zhu Long and Dr. Zhao.
Hi. Yeah. Good evening. Actually, now it's 7:55 p.m. in Beijing right now. So great. Actually, I think Dr. Nanda is at the same department with you, right?
Yes.
I know Nanda. Okay. Yeah. Great.
Did you get a hold of Ben? Wanley?
I cannot find Dr. Bing Shi, but never mind. I think we can just start on time and we can,
And he will
maybe,
come. He will come.
yeah.
Okay, so who do you want Warlick to introduce first? To go to you?
I think as you said, or Orla, yeah,
Yeah,
the,
yeah.
Our Lady-
Why doesn't Warlick just introduce you and you run the show?
Yes, yes.
And you,
Yeah,
okay,
yeah.
and you just run it,
So-
okay, Wanley?
yeah.
Is that
We
okay?
we can let Bing Shi introduce Dr. Shi Long after Dr. James Liu's talk.
Yeah, we'll just change it, just adapt a little bit. Right, Warlicks?
Okay, so Dr. Bin
On the
is
fly,
not here.
on the fly. On the
Okay, so
fly.
I'm going to introduce Dr. Yun Lee, and then he will run a show after me, right?
Yeah,
So this is the sequence.
introduce Wanley.
Okay.
He's the head of the cerebral vascular service in Beijing. You've been at the hospital. You got the hospital name, Tiatan. I think it's there. You got Wanley's profile there, Warlicks.
Yes, got everything. It's perfect.
Oh,
We
good.
can
No,
run
no.
in
This is Wanley's
Yes.
profile. Yeah,
Yeah.
and then he will take it from there. So.
Mhm.
So how are things in Beijing, Wan Li?
Actually, I think the weather is quite hot, but today there heavy rain, but still hot.
I don't know. I don't know
Summer
if
hot.
Miami is hot too. Not yet, though. Not yet. I
Okay.
think we're on opposite sides. We get hot when you get cold, and we get cold when you get hot. There's got to be a term for that.
Yeah.
Okay.
So walking the line between function.
Okay, you ready to start? Okay,
Yes.
Warlick, okay, I'll just count down and then you take, after I go one, you go, okay. And you don't have to say
Okay.
anything about neurosurgical TV because it's in the background. You don't have to say anything about that, okay?
I got you.
Okay, okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hi. Good morning from the Neurosurgical TV. This is a China Neurosurgical Journal webcast. So today we have two wonderful topics that we're going to present to you today. So first of all, I would like to introduce Dr. Yun Li Charles. He's a director and from the divisions of cerebrovascular surgeries, Beijing Tiantian Hospital, China. He has many experience in the surgery. So he's going to be host today. So please welcome Dr. Yun Li.
Hi, yeah, thank you. Thank you for the introduction. And today it's the sixth bi-weekly webinar of our Chinese Neurosurgical Journal. And the Chinese Neurosurgical Journal actually is the English language journal, the official journal of Chinese Neurosurgical Society. And we cooperated with Dr. John Burnett of the Neurosurgical TV to hold this webinar every 2 weeks. So today there will be the sixth webinar of this special channel. And we have two speakers. The one is, please allow me to introduce the first speaker, Professor James Liu. He's a professor of neurosurgery and director of cerebrovascular surgery and skull-base surgery of the Rogers, New Jersey Medical School Department of Neurosurgery. And today he will talk about walking the line between functionality and radicality in skull-base surgery. So please, Professor James Liu.
Great. Thank you, Dr. Zhao, and thank you to my friends and colleagues from China for this honorable invitation. It's a great pleasure to be here this morning to share with you some of my thoughts and philosophy and techniques on skull-base surgery. If I may share my screen. Can everyone see my screen? And
Yes, perfect, perfect.
Terrific. Well, I chose this topic, walking the line between function and radicality, and can you achieve both? And this is an issue I think we deal with on a daily basis as we tackle difficult, challenging lesions of the skull base. So when we think about lateral skull base surgery, we have a variety of different pathologies: acoustic neuromas, paragangliomas, petroclival meningiomas, and so forth. And these often can be challenging due to the deep location, involvement of the brainstem, and involvement of the cranial nerve functions. And so obviously we want to try to achieve a most radical resection from an oncological perspective, but sometimes we also want to preserve cranial nerve function. And so are we risking function at the cost of extent of resection? But can you achieve both? How can we achieve optimal cranial nerve function, but do a maximal safe resection and meaningful resection? And I think I'd like to highlight that concept with a variety of different pathologies in this lecture. The first I want to address is acoustic neuromas. And when we're dealing with these large COOS grade 4 acoustic neuromas that often compress the brainstem and displace the fourth ventricle, we want to achieve a gross total resection as safely as possible, but yet preserve their facial nerve. One of the movements that we've been seeing around the world is this concept of a planned subtotal resection followed by gamma knife radiosurgery. Some people have called this adaptive hybrid surgery, and you could see this is one of the papers that's been published on this concept of staying inside the tumor and then debulking it and then radiating it with gamma knife. However, the criticisms have are that this has resulted in non-specialty centers with less experienced surgeons doing this type of surgery. This is my own patient where she had undergone a retrosigmoid by a neurosurgeon in the community, and they did a subtotal debulking and told the patient, we got most of it, the rest is inoperable, and we can shrink it with radiation. The patient got radiation to the remaining tumor, and 3 months later she was quadriparetic and nonverbal and on the verge of going to a hospice care. Luckily, she was seen by a colleague of mine and sent to me for surgery. We did a translab approach based on the angle of attack, no brainstem or cerebellar retraction. And during surgery, the tumor was quite adherent to the facial nerve, so I trimmed it and left a cuff of tumor along the course of the facial nerve. And here's the scan at 10 years post-op. You could see a stable remnant. And clinically, she improved dramatically. Here she is at 2 months. You can see the loss of hair from her radiation therapy. And then at 6 months, and here she is at 9 years post-op, still doing well. So if we review the literature critically about this concept of adaptive hybrid surgery, they call this a nerve-centered approach. And if you review it critically, you will see that the subtotal debulking is intracapsular, and there's no attempt to come around the outside of the tumor. And although the tumor control rate and the facial nerve function of 96% preservation, Brackman 1 and 2, look very favorable, the long-term follow-up is short. And although this looks favorable preliminarily, we have to ask ourselves, are we doing the best for the patient doing this type of surgery? And some of my own personal criticisms include that the subtotal is planned, meaning I'm not even going to try to remove the tumor. The debulking is primarily intracapsular, so what happens is you often underestimate the volume of reduction and what's left behind. So you're left with a huge spectrum of subtotals, and not all of these subtotals are created equal. The data is lacking long-term follow-up, so we don't know what's going to happen in the next decade or so. And will we be creating a new emerging disease? And if we as teachers and professors are not doing state-of-the-art, safe and proper facial nerve dissection, how are we going to teach the new generation? And it will become a lost art. And so if we're not doing these difficult, challenging microsurgeries for acoustics, how can we perform these for these more complex lesions in the skull base? So I think just like open aneurysm surgery, acoustic surgery is becoming a lost art of microsurgery. And like I said, not all subtotals are created equal. You can see this is my own little classification of the chunk, the carpet, and the linearly visible. And we want to achieve the best resection towards the right of this curve. And the data shows that the more volume of residual left behind correlates with the risk of recurrence. And so, in essence, extent of resection does matter. So how can we achieve maximal tumor resection and still achieve the best facial nerve outcome? My personal strategy is that we need to go into each case with the intention of attempting a gross total in all cases as safely possible. And if we leave tumor behind, that decision is made intraoperatively based on our intraoperative findings and judgment. And if we do decide to leave tumor behind, we have to leave the least amount possible so that we maximize the extent of resection, in essence, achieving a radical near total as safely as possible. The technique that I've learned to appreciate is the one that was described by Sasaki here in 2009. And if you look at this diagram, the vestibular nerve ensheaths the tumor and the tumor capsule. And as the vestibular nerve stretches around the tumor capsule, there's a membrane called the perineurium that surrounds the tumor capsule. And if you pick up this plane and stay in this plane of cleavage, you'll find this clear membrane that looks like arachnoid, but it is not arachnoid, it's actually the perineurium, and it creates a layer of protection over the cochlear and facial nerves. So I'll show you in this video. This is a case of a medium-sized acoustic neuroma. We've drilled out the IAC and we divide the distal end of the tumor early on to find the facial nerve in the fundus. And then we come around the medial side and we undress the tumor by peeling the arachnoid membranes off of the tumor capsule. It's important to do early debulking of the tumor, so we hollow the tumor out like a canoe so that we can start to collapse the tumor and peel the tumor from this membrane. What you see there is the perineural membrane, and we could follow it along the medial side on the brainstem. And you stay in this plane. You see how we're keeping this clear membrane and carefully peeling it from the true tumor capsule. We'll now come on the superior pole of the tumor, find the superior vestibular nerve, and then define that perineural membrane, and then follow it to the porus acousticus. And here's where the tumor tends to be most adherent, right at the distal end of the proximal end of the IAC as it exits the porus. And then here, if there's any adhesion, you can sharply trim it. And here in this case, we got a gross total removal. We're stimulating the nerve, and you can see at the end it looks much like a glove. And you have to trust that the facial nerve is there behind that veil. It's stimulated at 0.05. You can see immediate post-op at 2 weeks, he's had a mild Brachman 2, but at 6 weeks already quickly recovered to a Brachman 1. Here's a much larger tumor. This is a more challenging cystic acoustic neuroma. These tend to be a little bit more vascular. They often can be more adherent to the facial nerve. And so here we're undressing the tumor and we're leaving the arachnoid over the 9th and 10th cranial nerves. There's the inferior vestibular nerve, and I'm using a scissors technique to spread, to carefully get right in between that vestibular nerve and the true tumor capsule. And if I follow that vestibular nerve membrane, it takes me to the perineurium, which is this clear membrane that you see right there. And on the other side of that is going to be my cochlear nerve and my facial nerve. So this is all sharp dissection using scissors technique, gentle retraction with peeling with my suction, very gentle. And those are the trigeminal nerve on the superior pole of the tumor. There's the trigeminal nerve. You can see it's compressed. And then I pick up the superior vestibular nerve and I'm dissecting it right between that and the tumor capsule. And there's the membrane. That's the holy veil. That's the membrane, and there's the 7th nerve. And that membrane is protecting my 7th nerve, and I can tell you that the nerve monitor is quiet this entire time because I'm not dissecting on the facial nerve. I'm not causing any direct trauma. That membrane is a beautiful buffer of protection. And now I use a disc dissector to gently do a disc push away technique to push away that membrane. And then any adhesions here, I sharply dissect using scissors. And this is where the tumor is very adherent. There's some tumor adherent right on the facial nerve, right on the membrane. So here's where I trim it, and I leave this little nodule here. Every time I touch it here, the nerve stimulator will go off. So I'm gonna leave that little nodule intact, and the nerve stimulated at 0.05 milliamps. And you could see, this is the recovery room. Intact facial nerve, Brachman 1, excellent removal that I was very happy with, and so forth. You can apply the same technique to translab. This is a case I did translab, and you can see it's pre-sigmoid translabyrinthine. We're going to undress the tumor and then continue to use this sharp dissection. There's the facial nerve in the distal area of the porus, and then we'll peel that membrane. Here we're going to pick up that subperineural membrane, and then here's the facial nerve at the distal end of the IAC. Go ahead and debulk the tumor, and then carefully use gentle spread technique. And then here's the membrane. Here's that perineural membrane, and this is where the tumor becomes quite adherent. So I'm trimming it. I leave a little remnant right here on the membrane, but now once I trim it, I've released it, and then I can continue to carefully peel the rest of it off. Be mindful of how much coagulation you use. I use minimal, so if you're going to use a bipolar, close to the tumor capsule. You don't want to cause thermal injury to the nerve. And a little gentle minor bleeding you can control with Surgicel. And this repair technique we've developed for translab using a fascia lata sling, putting the fat graft on top so that the fat doesn't herniate and compress the brainstem. And you can see here's the post-op scan, immediate Brachman 1 with a radical near total removal. So here are some examples of near total removals. These are all large tumors, near to gross total, but the MRI looks very similar. They all have Brachman 1. And then here are near total removals. And again, excellent facial nerve. So what we've noticed is that if a patient developed a mild palsy, what we've seen is that the recovery to a Brachman 1 and 2 can happen as early as 6 weeks. So I believe that buffer, that membrane, really protects the facial nerve, and we're having faster recovery. Here's a patient that didn't recover, but went as good as a Brachman 3, and you can see this is a less optimal result that we'd like to avoid. But when we tracked our outcomes, we're now up to about 130 consecutive patients or so, but you can see our Brachman 1 and 2 rate is about 95%. So I also want to address that although the retrosigmoid approach is the workhorse for CP angle, we have to consider alternative transpetrosal approaches for specific lesions. As you know, the petrosal approach can be broken down into an anterior or posterior petrosal, or even combined. And so here's an example of a trigeminal schwannoma. You can see this has a dumbbell shaped. This patient was having some hyperreflexia, imbalance, and facial numbness. And so here we'll do an anterior petrosal approach. It gives us a short distance to Meckel's cave, and this is the exposure that we're going to get. We're going to be able to see the tumor in the CP angle and also in Meckel's cave. So we'll do a right-sided anterior petrosal approach, Kawasi's approach. And so here's the middle fossa exposure. There's the middle fossa rhomboid that's bordered anteriorly by V3, and then posteriorly by the arcuate eminence and laterally by the carotid. when you drill this rhomboid structure, you can now open the posterior fossa dura, open up the tentorium, we'll ligate the superior petrosal sinus on the way in. And then the key here is to open up the fibrous ring of the porus trigeminus. This is where the trigeminal nerve enters into Meckel's cave. And now you'll have full exposure of the tumor. We'll start in the CP angle by undressing the arachnoid, debulking the tumor to make it smaller so we can collapse it. And there's the 7th and 8th nerves right here. This is 7 and 8 going into the IAC. Here's the brainstem and AICA. And now we'll carefully peel the tumor from the 5th nerve. And when you're doing trigeminal schwannoma surgery, it's very important to preserve as many fascicles of the 5th nerve as possible until you find the origin where it originates. And so if you do this, you'll minimize the facial dysesthesias. And then here's the final view. Here's the brainstem, and then there's the 5th nerve going into Meckel's cave. And then we get a nice complete removal of the tumor here. Here's another example of a trigeminal schwannoma, much larger. You can see it's compressing the brainstem, causing gait ataxia. And you can see that in this case, it's more extensive, and so I chose a combined petrosal approach by adding the pre-sigmoid exposure to my Kawasi's exposure so that you get this double martini, as Professor Al-Mefti describes it, this type of view where you have multiple angles of attack. And so we'll do this through this combined petrosal approach. This is a video we published in Operative Neurosurgery last year. You can see we'll come in subtemporal and pre-sigmoid. We'll cut the tentorium after we ligate the superior petrosal sinus, and we'll cut the tentorium towards the free edge, being careful to protect the 4th nerve. We'll release the CSF, and there's the tumor in the pre-sigmoid space. So we have a beautiful view. There's the trigeminal nerve on the superior pole of the tumor. And there, eventually we'll find the 7th nerve on the lower end. But look at the wide exposure that we have. After debulking the tumor, we can now see the brainstem. And there's the 7th and 8th nerves on the inferior pole of the tumor there. So now we'll carefully peel the tumor from the brainstem and then debulk the tumor, as these schwannomas tend to be more soft and suckable. The critical thing here is the medial side. The medial side is always the most vulnerable. That's where the 6th nerve is. It's always the last nerve that you see. And be careful of the 4th nerve, which is also vulnerable. It's usually on the superior pole of the tumor. And you have to look subtemporally here. I'm just carefully moving the retractor. Now I can see the 4th nerve. And there's the trigeminal nerve. So we can also follow this into Meckel's cave. We open up the porus trigeminus. There's the soft tumor in Meckel's cave. And beautiful view of Meckel's cave. We can mobilize the 5th nerve and then carefully dissect the tumor away here. There's the brainstem. Here's some perforators coming off of the basal artery. We're being careful to look for the 6th nerve. And then there's the last component of the tumor. There's the 6th nerve. There's a little microscopic tumor adherent to the 6th nerve. We're going to leave that behind. And this is how you preserve function. You know, little microscopic adherences, I generally will leave attached to preserve cranial nerve function. And of course, meticulous closure is very important to prevent CSF leak or reconstruct the the skull base with a little cement, a fat graft, and then the pericranial flap that we've harvested here to prevent any CSF leak. So the result was a near total removal, but you can see radiographically, you don't see any residual tumor, and the patient was neurologically intact. So when we talk about skull-based meningiomas, these are very challenging lesions, and they occur in anywhere in the skull base from anterior, middle to posterior cranial fossa. There are a number of approaches to get to these areas. I want to address the topic of petroclival meningiomas because these are the most formidable, treacherous lesions because they often can encase the vascular structures, namely the basilar artery and perforators and sometimes cranial nerves. And these must be differentiated from other CP angle tumors, such as this one. This is a petrotentorial or posterior petrous meningioma. This one happened to have IAC extension. But these tumors, unlike petroclival tumors, originate lateral to the fifth nerve. And so the cranial nerves tend to be displaced medially so that the nerves are on the other side of the tumor. And so technically it's a little bit easier to remove. Whereas petroclival tumors, the cranial nerves are situated between the tumor and the surgeon. So you end up working through smaller corridors, making these more difficult. And so when we're dealing with petroclival meningiomas that tend to be large and extend above the level of the tentorium, I generally will choose a combined petrosal approach, and this is done with a pericranial flap, and I often will do a subtemporal craniotomy combined with an extended pre-sigmoid mastoidectomy. And if the hearing is intact, we'll keep the otic capsule with a retrolab variation. And so here's a video that we published some years ago using the retrolab technique and doing the anterior petrosectomy, combining it with a Kawase. Here we'll open up the subtemporal dura and then ligate the superior petrosal sinus here with a suture ligature. And after we ligate it, we'll cut the tentorium to get better exposure into the CP angle. It really opens up that corridor. When you cut the tentorium, you have more angles of attack. There was the lower cranial nerve, the 7th and 8th nerve that you saw there. And now we can just carefully dissect right on the brainstem. We have a beautiful view of the brainstem. And then we can further open up the tentorium as we further debulk the tumor. We can open this up into the porous trigeminus, opening up Meckel's cave. So here's the 5th nerve. You can see how we're working right on top of the 5th nerve, and we have this beautiful view. And now we'll carefully, using a sharp dissection, peeling this tumor from the tentorium here. Opening up into Meckel's cave. Now it's important to sequentially debulk the tumor. As you debulk the tumor, it makes the tumor smaller, and then you can work with a smaller tumor and continue to work around in an extracapsular fashion, looking for those critical structures and being careful to work and identify where those critical structures are. So here you can see this is the final view with an endoscope. I often will use an endoscope in the CP angle looking for any residue. And then we'll use the fasciolata sling technique that I developed showed you earlier, that it will hold the fat graft, and we'll use the pericranial flap at the end. So here's the post-op CT scan. You can see the multiple variable angles of attack, and here a complete removal. Here's the delayed post-op MRI scan and intact neurological patient. So ideal outcome. So the variations of the petrosectomy are as such. You can start with a retrolab, pay attention to the otic capsule here, and as you remove it, you can also remove the posterior and superior canal, called the transcrucial variant, and still preserve hearing if you wax off these inner membranous canals. And if the hearing is already out, you can do the full translab. And the most aggressive one is the transcochlear, where you mobilize the facial nerve. However, we've largely abandoned this one because this usually results in a facial nerve palsy that improves as good as a Brackman 3. So when we do the transcrucial approach, it's important to wax off the membranous canal as you're drilling it, and you get this extended view to the CP angle. And this is a case where I chose to do that. You can see this is a large petroclival meningioma with the brainstem and cerebellum wrapped around the backside. Coming in retrosigmoid here, I think would be very difficult, at least in my hands. But coming in transpetrosal, you get a wide angle of attack and access to Meckel's cave. And this is a video we published just recently showing you this technique. So here's the vein of Lebet. If you see this type of variant, you can cut the dura around the vein of Lebet so you don't injure it. So always pay attention to the vein or veins of Lebet. It's very important to preserve that. And so we'll go ahead and ligate the superior petrosal sinus and then debulk the tumor here. So now you can see here are the lower cranial nerves. And then we can now debulk the tumor, opening up this area, carefully peeling the tumor away from the 5th nerve. And so now here's the, here's the 7th and 8th nerve now working above it. And then here's the trigeminal nerve. And then there's the basilar artery in its depth. There's the basilar artery. And so now we're going to go ahead and open the rest of the tentorium into Meckel's cave. This is a recurrent theme, a technique that I do often to get into Meckel's cave. Here you can see soft tumor coming out of Meckel's cave. And the key here is using sharp dissection when you're doing meningioma surgery. These tumors are very adherent to the arachnoid. So the key here is to cut the arachnoid on the tumor. So you release the tumor from the adherent arachnoid so that the arachnoid falls towards the side of the vessels and the cranial nerves. So you stay on the tumor capsule, you can peel the tumor capsule away. And so now we're going to look for the 4th nerve. You can see we can deliver this tumor after we've incised the arachnoid. We can now deliver the tumor. Luckily, this tumor is soft. And there's the 4th nerve. You can start to see the 4th nerve. Here's the 4th nerve. And you have to sharply dissect all of the adherent arachnoid adhesions just to release the 4th nerve. And then we'll just go ahead and debulk more of this tumor, saving this 4th nerve on the top. This is probably an SCA vessel here. You see how we're trimming the arachnoid. You don't want to pull, you want to sharply dissect and release the tumor from the critical structures. So almost a purely scissors technique. You don't see any blunt dissection, all scissors. And you could use the scissors as a dissector. That's a single blade, open blade technique I use. And then carefully delivering the tumor. So here's the endoscopic view. You can see beautiful view. And then the fascia lata sling reconstruction technique. So we've shown you this technique, and so here is the final view. This is a radical near total, and we were able to preserve hearing and facial nerve function. Here's another combined transcrucial approach for this large meningioma. I left a little residue that was stuck onto the brainstem. And then here's another one, a combined petrosal approach. So I think the challenge here is to know when to stop and when to determine that you've made a meaningful removal. so that you can make the residue a favorable radiosurgical target. And so here's the remnant of the tumor that's just in the posterior cavernous sinus, where a lot of the cranial nerves were entering through the tentorium. And so the patient had an excellent result with that. And if you look at the large series here from Fukushima, who's selected to do pursuing a near total rather than gross total, and the series from Shekar, you could see aggressive but judicious tumor removal, leaving remnants for radiosurgery. This has been the trend for treating petroclival meningiomas, and the series from Al-Mefdi as well. So I think this is, the pendulum has certainly swung from previous decades where we were doing radical gross totals to now more conservative resections to preserve function. Cavernous sinus. Cavernous sinus is again an area of controversy. I think especially when we're dealing with meningiomas, this is a critical area where a lot of important structures reside. My general policy for cavernous sinus for meningiomas is that we resect the safe extracavernous component and leave whatever is intracavernous for radiotherapy. And you can separate the two using this technique of the anatomical lateral wall of the cavernous sinus. We peel the dura propria off of V1, V2, V3 by unlocking the cavernous sinus, and you can create that plane of separation. Let me demonstrate that in this large complex spheno-clinoidal cavernous meningioma. Look at the ICA and MCA, they look encased. This is invading the cavernous sinus. Very challenging tumor, a lot of mass effect on the brain with shift. So the idea is that you want to unlock the cavernous sinus, but also unroof the proximal optic nerve and clinoid, so you have this view of proximal control of the nerve and the artery, because everything on the inside is going to be displaced, and this helps you find the normal anatomy. I'll demonstrate this in this video. Here we've unroofed the left optic nerve canal that you see here. We've taken out the clinoid, and now we'll open up the dura and then open up the Sylvian fissure. And here is the MCA following down to the ICA. And once you know where the ICA is, you can now safely debulk, because you know where the artery is on the other side. If you don't do this, you can overshoot and put a hole in the carotid with that device. And the key here is to incise the tumor directly over the ICA. The ICA is a natural border that will divide the tumor into compartments. You can now have a lateral compartment of the tumor and then a medial compartment relative to the ICA. And then you could follow the tumor into the optic canal. We open up the falciform ligament to get early decompression of the optic nerve. And now we'll work on the lateral component by debulking the tumor, incising the dura propria so that we can start to peel the lateral wall. This is the tumor stuck to the lateral wall. And then there's the cavernous sinus. This is the intracavernous component. And we can continue to peel the tumor off and then make the Dolenz cut on the roof of the cavernous sinus. So we release the lateral wall. There's the lateral wall, and now the rest of the tumor here is stuck to the brainstem, the cisternal segment. We'll come in pretemporal, release the CSF from the posterior fossa cisterns, and then start to peel the tumor away. And it's important to trim the tumor, so you make it smaller. You don't want to work with this large tumor. And here, the idea is to find the carotid, find the perforators off of the pecum and the choroidal, and then find the third nerve. So here the third nerve was actually pushed medially up against the carotid. There's the SCA vessel, and we're carefully peeling the tumor from the SCA vessel and we'll use a 3 hands technique using a Sonopet at 12 o'clock while I can deliver the tumor into the vacuum. And then there's the M1 and A1. So now that we've taken care and controlled the lateral compartment of the tumor, we'll now work on the medial compartment, working along A1. What you'll see here is that the optic nerve has been displaced medially and inferiorly, and you can see it's a flattened optic nerve going into the optic nerve canal. And then here's the third nerve. You can see the third nerve coming in, and then we'll use a 3 hands technique to remove there's the third nerve going into the tentorium. And then again, the 3 hands technique where I can protect the structures and deliver the tumor into the vacuum. There's the free edge of the tentorium. Here's the final view. You can see the carotid, the optic nerve, and then the extended pericranial flap that we use to reconstruct the skull base defect. So here's the final view. You can see here we've separated the extracavernous and left the intracavernous for IMRT radiotherapy. So this is the strategy that we employ. And it's important to know that there are some complications and pitfalls with skull base surgery, namely ICA injury. Here is a clinoidectomy that I performed, and you have to pay attention every second of the way. You can see we're drilling the clinoid here. Here's the optic nerve that's been unroofed, and there's the optic strut, and then here's the clinoidal space here. I thought this was a venous channel, but you could see when you're paying attention to the optic strut, you need to pay attention to all surfaces of the drill. Now the distal end of the drill here has made a little weakening of the adventitia of the clinoidal segment of the carotid, and you can see before you know it, brisk arterial bleeding is encountered. This is not venous bleeding, and you have to recognize this because you don't want to make the mistake of injecting Surgiflow here, otherwise you'll create a stroke, and you want to keep your suction in the field. Our general reaction is to like shove and cover it, but if you leave the suction in the field, it allows you to understand where is the injury, what is the nature of the injury, and how can I repair it. So here I'm trying to attempt to coagulate the edges together. You can see I fail miserably, but now I remember I can use a crushed muscle graft easily taken from the temporalis and then seal off the hole. And so I applied some pressure here for about almost 45 minutes, and I was able to stop the bleeding and then proceed with the rest of the tumor removal, luckily. And you have to go down to angio to check. There was no pseudoaneurysm on the early or delayed angiograms, and she ended up making a nice recovery from removal of this tumor. Here's an example of probably not choosing the right approach, having limited access. So this is a tumor that was epidermoid that was quite extensive, wrapped around the entire brainstem here. And my initial thought was to come in with a retrosigmoid that extended through the foramen magnum to get to this tumor, and this gave me this angle. But I couldn't retract the cerebellum much because it resulted in facial nerve irritation. So this is the angle of attack that I got, but you can see there's tumor wrapped around the other side of the brainstem. And I didn't realize this tumor was very adherent to the 6th nerve, and as I was delivering these pieces, you could see I saw a severed end of the 6th nerve. Luckily, if you recognize this, you have to find the other end. Make every effort to look for the other end, because the 6th nerve is one of those nerves that can make a full recovery if you repair it. And some people have tried to glue the new nerves together, but I prefer to anchor it with a suture end to end, because you never know if the wave of CSF will wash your two ends away. And so here we're putting in a 10-0 suture single interrupted suture working in between these tight corridors. But you have to find these two ends, and you just put a single suture in. You don't have to put many sutures, just a single suture with a couple of ties, and this will get the two ends together. This is peripheral nerve surgery principles in the skull base. And so here's the endoscopic view. You can see we'll rest the repair on the petrous bone so it's more stable, and I'll put some Surgicel and glue to hold that together while it heals. And you can see this is the residual tumor because I wasn't able to look around the corner. And here you can see at 4 months, there's a little bit of partial recovery. And then at 7 months, she's already made a full recovery and the 6th nerve palsy has resolved. So a very remarkable recovery. However, at 9 months, this residual tumor is starting to grow again. So what am I going to do now? So the approach that I've chosen to get to this area of the tumor is the Kawasi's approach, because this helps me to look backwards. Here's the petrous rhomboid, and we extended it to incorporate a little bit of presigmoid to see the otic capsule. And then now we can look backwards on the brainstem. Here's the 7th and 8th nerves, and this is the area of the blind spot that I wasn't able to see before. I can now remove that area, and there's the basilar artery and the 6th nerve. And then there's the 5th nerve and the 4th nerve visualized. So a nice, excellent outcome choosing an alternate skull-based route. And here's another example of a huge meningioma in the infratemporal fossa. This was treated by another surgeon years ago, and they left residual on the petrous ICA. Very reasonable, very good resection, and treated with radiosurgery. Unfortunately, this progressed and recurred. You can see it's filling the temporal fossa, going into the jugular foramen and jugular bulb. So here we did a balloon test occlusion, which she passed, and so we're going to resect the petrous ICA here and resect the jugular bulb as well. So this was in essence a cochlear, transcochlear type approach, and the patient had a Brackman 6 palsy to begin with. So we found the two ends of the facial nerve that you see here, and we did an interpositional facial nerve graft with a sural nerve, and she had a nice complete removal of the tumor. And you could see she started with a Brackman 6, and she ended up with a pretty good 2.5 that I'll call it here, with a pretty good improvement of her facial nerve function. So lastly, I'll conclude with the jugular foramen. This is a very tough area to get to. This is the approach I learned from Dr. Fukushima using a combined transmastoid infralab approach. This is the mastoid neck exposure that you have classically seen, infralabyrinthine. You can go intra as well as extradural. And here's an example of a patient who presented with Vernet syndrome, cranial nerves 9 through 10 palsies. You can see hemiatrophy of the tongue and a winged scapula, significant for 11th nerve palsy. Here's the MRI scan showing this chordoma. It initially appears midline, but you can see it's not midline, it's actually quite lateral. It's in the parapharyngeal space, it's in the CP angle brainstem, and it's in the jugular foramen. So what approach will you do here? Here we'll do, you can see again, this is the erosion of the lower clivus, craniocervical junction. He's got instability, and we'll do this through a lateral approach. This is the lateral, extended lateral, anterolateral approach. We'll skeletonize the facial nerve. Here's the tumor in the occipital condyle that's been eroded. There's the V3 segment of the vertebral artery. I'm going to skeletonize it and prepare it for transposition if needed. And it turns out that I did not end up needing it. We'll do a fallopian bridge technique, skeletonizing the facial nerve, leaving it in the bony canal for protection. We'll ligate the internal jugular vein and open up the sigmoid sinus and occlude the proximal end so that we can inject Surgiflow distally to the inferior petrosal sinus to stop any back bleeding from the IPS. And then we'll open up the jugular bulb. You can see there's tumor here in the jugular bulb. This is soft chordoma, very extensive. And now we'll go into the neck and debulk the tumor in the parapharyngeal space, debulking it all the way, and then excising the rest of the tumor towards the jugular foramen. So that takes care of the extracranial component. Here is the portion that's in the C12 joint. We've taken off the occipital condyle, and now we're taking off the tumor that's right on top of the craniocervical junction. There's the lower clivus that we're drilling. We're drilling the bottom of that clivus. And then there's the tip of the odontoid process where my suction is. And we're going to drill off the tip of the odontoid process and then remove the rest of that tumor. Now we'll chase the tumor intradurally. There's the ipsilateral vertebral artery, following the vertebral artery towards the VB junction, and we can protect the artery and resect all of the tumor that's ventral to the VBJ. These are the lower cranial nerves. They're not functional, so we can divide them as they're invading, encased by the tumor. We'll resect the ventral dura. There's the VB junction at the end of the resection. And here's the big skull-base defect. We'll repair this through an alloderm graft. We occlude the middle ear so we don't get CSF fistula, and we'll put a big fat graft and a mid-port plate to reconstruct this. So here's the pre-op, here's the post-op, a near total removal, and we come back for a third stage for occipital cervical stabilization, and he did quite well and went to radiotherapy. So lastly, here's a glomus jugulare tumor. You can see it's filling and impacting the jugular vein, very hypervascular. These you want to embolize aggressively, and again, we'll use the same approach using a extended anterolateral approach. This is the portion that's in the middle ear, and we'll go ahead and remove that, and we'll tie off the internal jugular vein, open up the sigmoid sinus, and we'll occlude the proximal portion endoluminally with this piece of gel foam, and then inject the injectable gel foam distally towards the IPS. We can now open up the sigmoid sinus, and the key here is to do intra-bulbar technique where you preserve the medial wall of the jugular bulb. This will help you preserve the lower cranial nerve function. Here's the tumor in the top of the jugular bulb. And then using Surgicel along the back bleeding from the IPS. Now to open up this area, you have to open up the rectus capitis lateralis. This helps you connect the exposure from the neck to the top of the jugular bulb. And then we'll open up the internal jugular vein. This is the tumor that's in that top of the internal jugular vein here, using sharp dissection to release all these fibrous adhesions. Now we can see the smooth wall of the top of the jugular vein. You can see more channels from the IPS. And then we'll now go ahead and open up the internal jugular vein. And what you'll see here is that intraluminal tumor here. Peeling this tumor away, you can see it has a nice encapsulation, and we can remove this portion of the tumor in an en bloc fashion. So there's the rest of the paraganglioma, and this is all extracranial, no CSF leak. All the lower cranial nerves here are preserved. So there's the pre-op scan, there's the post-op scan. And so I'll conclude I think maximal safe resection and cranial nerve preservation can be achieved. You can do both. You just have to make the right intraoperative decisions, but you also have to choose the optimal surgical approach. Our intention should be to perform maximal safe removal, and if we have to leave residual, this should be based on intraoperative observations and judgment, and we should try to leave the least amount to make it the best favorable radiosurgical target. It's very important to work as a team, and I'm blessed to be surrounded by a talented group of people on the skull-base team. Here are my colleagues from various departments, and our endoscopic skull-base team as well. So thank you for your attention, and it's been an honor to be here.
Thank you, Dr. James Liu, for your nice talk. I think the skull-based surgery is always very interesting and very challenging for many neurosurgeons. And you give us a nice talk and very high quality surgical video. I think there are some questions from the audience. The one is in your experience, when you resect schwannoma in CP angle, you found intact and anatomical presentation of facial nerve, but post-operative you see paresis. And how often you see this?
So I think the question is, how often do you see immediate post-op paresis? I would say it depends on the size of the tumor. I think, the more we're using this technique, we're seeing less and less of immediate post-op paresis. I would say the rate of seeing post-op paresis in a large Kuss grade 4 tumor is about 10 to 15%. And most of the paresis is between a Brachman 2 or 3. And what we're seeing is that majority of these are recovering as early as 6 weeks instead of 1 year. So, I think the idea is to avoid direct contact to the facial nerve, leaving that membrane as a layer of protection so that you don't injure the vascularity.
Thank you. And I just noted that you mentioned about in your team there endovascular doctors. So what about your opinion for the preoperative embolization of the blood supply for the tumor, especially those large meningiomas? I guess for schwannoma, there's not necessary for embolization. But what about meningioma?
Yeah, that's a great question. I rarely use preoperative embolization for meningioma, especially for skull base. I think usually when you're doing a skull base approach, you can devascularize these quite aggressively because you're at the base and you're at the origin. We generally will use angiography sometimes if we're trying to understand the venous outflow, looking at patencies of sinuses and draining veins and so forth. But for meningiomas, we rarely embolize them, but for paragangliomas, it's almost routine.
Thank you. So are there any questions? Dr. Lima, Dr. Bing Xu?
Hello, James. Very nice presentation and very impressive results. And in my experience, the soft schwannoma are relatively easy to preserve the nerves, but sometimes the tumor could be hard. Like today, I have a hypoglossal schwannoma. It's pretty very hard. So it's if the schwannoma is quite hard. How to preserve the nerve?
Yeah, those are difficult ones. I think you have to find an instrument that can debulk the tumor. So my first choice is usually a ultrasonic aspirator, and I slowly adjust the strength higher and higher to get enough adequate debulking. But even if you can't use an aspirator, then I will cut portions of the tumor out with a heavier micro scissors, more aggressive micro scissors, and that can generally help debulk the tumor. And then once you get to the nerve structures, it's all sharp dissection to trim the tumor off. And then if it's very adherent, then I'll try to create a pseudo plane, so you leave a thin cuff on the nerve to preserve it if there's no plane.
Excuse me,
So,
John.
so what
Go ahead.
would be your first consideration to totally resect the tumor, or just or preserve the nerve? If it's very difficult to achieve the total resection.
Yeah, I think if it's difficult to achieve a total resection, I think you have to think about preserving function. So, but you don't want to leave a large residual at the same time. So you have to do your best to get as much of it out as safely as possible, and leaving the least amount of residue. You know, you have to find instruments that will help you achieve that and get that type of performance. So, but of course, you know, we don't want to injure the nerves, and try to avoid that as possible. If you have to leave a residual, you know, sometimes you have to, for patient safety, and then use radiotherapy if needed.
Yes, I agree with you. Yeah, the nerves function may be the most important thing.
Excuse me, James, I have a question of Ben. Ben, we're televising this now on WeChat, correct?
Yes, yes.
Can we ask the Chinese audience if they want to ask a question? They just ask it in Chinese. Can we do that? And then.
Oh, actually,
you
they are at another platform, and
Okay.
I will check it.
Okay, that'd be nice if we could work out the Chinese audience being able to ask James questions.
Yeah, tonight there already 1,700 audience.
Oh, great, so that's great,
Yeah,
1,700.
Yeah.
Yeah, it'd be great to have that audience if they had a question, if they could somehow post it somewhere, or we could work on that in the future, maybe.
Yes, they just say that it's a very excellent presentation.
Okay, if they have a question, tell them
No.
that you can ask a question live in Chinese.
Yeah.
If they have a question, just tell them to post it, and we'll address it.
Hi, John.
Good day, Harshad. Go ahead. You want to ask a question while we're waiting?
Yeah. Hi, Professor Liu.
Hi.
Hi. Nice to hear you again. I've heard you so many times, and it is always wonderful. And every time I add something to my knowledge and understanding of the subject of skull base and vascular lesions. Wonderful presentation you have shown. And yes, I was asking that same question of intrathecal preservation of facial nerve and post-operative paralysis, which may be grade 2 of Brackman, and slowly it recovers. But this I've seen very often happening in many of the cases, although we preserve the arachnoid around the facial nerve. That's what I was asking. What actually happens? Why it happens? I can't make out. Although on a nerve stimulator, you find the nerve is intact.
Why do we experience facial palsy even though it's anatomically intact?
Yeah, yeah.
Well, I mean, I think it depends on what you're seeing intraoperatively. You know, if the nerve monitor is firing, if there's irritation, so that can also contribute to facial palsy. I think you have to one technique that I didn't mention is I also use motor evoked potential in addition to EMG. So it gives me a second modality of confirmation that the nerve is intact, but also firing in continuity. So I think the when you get a facial palsy afterwards, it's probably from some edema in the nerve or some trauma from the dissection. Um, so I think it's rare to have a big palsy if there's no irritation during the case. Um, you have to think about maybe thermocoagulation injury that can possibly happen where the monitoring is silent and you wake up with a facial palsy. So be careful of using thermal
Thank
coagulation.
you.
I try to avoid it as possible. And if something is bleeding, I try to find other means of controlling it.
Okay, Ben, any questions from the
Thank you.
Chinese audience?
John, can I ask one more question?
Oh, go ahead, go ahead.
I totally agree with Dr. Bin Zhu, who has tumor.
We're kind of losing the bandwidth. Any questions, Ben, from the Chinese audience?
No, not in the WeChat.
Okay, okay.
Okay, Professor Liu, this is Lima from Tiantan, and can I ask a question? And thanks
Sure.
for your amazing lectures for the skull-based surgery. You show many possible cases and very excellent results from them from the many possible transpetral approach. Because in China, I believe many surgeons don't do the surgery in that way. That's really amazing for you to show to us. And thanks for your contents. And I only have a very simple question. Because I noticed that your surgery is very clean with little bleeding when you do the schwannoma. So after the debulking, do you think it's always necessary to stop the bleeding? Because in China, I notice some professors, they don't do that. And is that always possible to find the perineural membrane when you do the schwannoma?
Great question, Lee. Thank you for your comments. You don't see it in the video, but after each cycle of debulking, there's always going to be bleeding inside the tumor capsule. So I will spend some time to coagulate so that you could proceed, because you don't want active bleeding as you're dissecting the plane. So after you debulk internally, you should coagulate inside the capsule, and that's relatively safe to do. And then once it's dry, you can proceed with extracapsular dissection. In terms of finding the plane, I think it's always possible. You have to try. I find that you have to avoid coagulating the dorsal aspect of the tumor capsule. You can coagulate initially, but you don't want to aggressively coagulate the capsule because you'll lose the visibility of the subtle differences of the vestibular nerve fibers and the true tumor capsule. So what I do is I go on the periphery of the tumor and then I use a scissors to spread. You can find the vestibular fibers on the surface and then start to spread to separate it, and you'll find it on the periphery of both poles. You can do that.
Okay, thank you so much.
Hello, Professor Liu.
Okay, thank you
So
again.
yeah,
yeah.
I have a last question.
Okay.
So I know some ENT doctors, they use external auditor meatus approach to resect the very small acoustic neuroma. Do you think it's necessary when the acoustic neuroma is still very small, like 3 or 4 millimeters?
Yeah, that's an interesting question. So Professor Bin Zhu is referring to the endoscopic approach for acoustic neuroma through transcanal through the ear canal.
Yes.
And the indications are extremely small. The indications have to be, it's very limited. It's based on a very small tumor that's very distal, and I believe the hearing probably is already impaired in those cases. And it's a small working corridor. I don't use this approach. Usually if I have a small tumor that small, generally we don't operate on those tumors anyway. We monitor them or they go to radiosurgery. But you have to think about that approach. I think it's an approach that since you're working in such a small limited field, you're going to have a higher rate of injury to facial nerve, but you're also going to have an opening through the external ear canal. So if you have a CSF leak, it's much higher than if you did a traditional retrosigmoid or middle fossa approach. It is an approach that I think more people are trying to do, but I think it's important to ask yourself when you're using a new technique, is it going to produce a better result than the current technique I'm using currently? For me, I don't think I would achieve a better result using that approach compared to a standard retrosigmoid or translab.
Okay, thank you.
Okay, thank you, Dr. James Liu. Thank you again. Okay, let's move to the next speaker of this webinar, Dr. Long Xu. Dr. Xu is a professor of neurosurgery of Beijing Tiantan Hospital, and today he will talk about the detection, repair, and the reconstruction of brain functions in patients with disorders of consciousness. Actually, it means how to awake the coma patient. Okay, please, Dr. Xu.
Thank you, Professor Zhao. Can you see my computer screen?
Yes, yes.
Okay. My name is Long Zhu. It's my first time to join this meeting tonight. Really, it's evening in Beijing. I'm a neurosurgeon in Beijing Tiantan Hospital, and I used to be a neurosurgeon specializing in neurointensive care unit and trauma. I began some research work in consciousness issues about 5 years ago. I began to specialize in clinical and research work related to disorders of consciousness. So the title of tonight's report is Detection, Repair, and Reconstruction of Brain Functions in Patients with Disorders of Consciousness. So this topic comes from a very important clinical situation, which we used to call vegetative state. For instance, one young lady suffered from car accident about 6 hours before she came to our hospital. Unfortunately, she lost the breathing for 4 hours. The blood pressure, heart beating were okay. We used mechanical ventilation with ET treatment. The patient was in deep coma. The CT scanning shows left frontotemporal subdural hematoma and a cerebral contusion and a serious brain edema. We did surgery immediately with decompressive craniectomy. After surgery, GCS scoring became better, and the CT scan became better. we gave her hyperbiotic HBO therapy, but no good. Finally, this young lady was rescued, but became VS. So let me first review the guidelines of severe traumatic brain injury. This paper was published online in 2016. Also, we translated it into Chinese version. We evaluated the effect of DC surgery, I mean the decompressive craniectomy surgery, and found that if we took GOS scoring 2 and 1 together, there was no significant difference between the DC group and the undo one. So the result is also too desperate. So that the question arises that is vegetative state the endpoint of severe TBI? The VS problems is another essential social issue, not just a medical problem, such as the famous racing star Michael Schumacher had 2 operations for STBI caused by skiing. He spent an unimaginable amount of money and finally out of coma. And another famous politician, the former Israeli Prime Minister Sharon, suffered a cerebral hemorrhage and fell into coma for 8 years. In 2013, the functional MR detected a significant brain activity signal, but died next year. As the main medium of China, CCTV, reported, we had tens of thousands of VS patients every year and aroused many concern and discussion from society and from our common people. So we are so confused about all these problems. What happens during the therapeutic recovery? Are there any key prognosis indicators and targets for intervention? About 50 years ago, these 2 professors defined such patients, those who are unconscious and unresponsive to themselves and the environment, but retain behaviors such as the sleep-wake cycle, are called persistent vegetative state, PVS. In 1994, the definition was clearer. The patient completed losses the perception of himself or herself and the surrounding environment, but preserved the functions of the hypothalamus and brainstem. In China, the 1996 Nanjing Conference of Chinese Medical Association showed the same details in some consensus. In 2020, the consensus of domestic and foreign experts together was released almost at the same time. It gave a clear definition of the disorders of consciousness, DOC. The coma time should be over 4 weeks to become chronic DOC. And DOC includes many states of patients, such as VS, MCS, MCS minus or MCS plus, and EMCS and other states. In the last 15 years, DOC is becoming a hot field in neuroscience research. The task functional MR was used to detect the activating signals. The EEG was used also to detect the connectivity and responsiveness and complexity of all of the brain. The clinical evaluation scoring system is also consistently improving. So we use all the tools and techniques to test or to discover the residual brain functions of the DOC patient. The most important thing, I think, in DOC patient clinical evaluation is to identify the MCS patients from the whole group, because the strategy and the treatment and some ethical problems is quite different. In terms of pathophysiological mechanism, the assessment and the diagnosis of consciousness relies on two dimensions of arousal and awareness. Regardless of the method used, including function MR or EEG or something else, we will try to find quantitative indicators of awareness as a basis for treatment strategies. In this picture, I have classified some methods of brain function examinations from the perspective of temporal resolution and spatial resolution, as well as whether it is invasive or non-invasive. Excluding all the animals and laboratory methods, the clinical methods are almost in the blue area. We can see EEG, MEEG, function MR, PET. In this table, I summarized of the advantages and the disadvantages of commonly used clinical brain function testing methods. At present, the most commonly used are still EEG and MRI. And so we can see that each tool and each technology is not that perfect. This is the PET signals reported by Professor Loris. He is a famous professor in this field. We can clearly see the difference between MCAs and VS patients at the metabolic level. However, PET test is too expensive for most patients. This is the perfusion MRI of a DOC patient in our center. He suffered from poisoning by carbon monoxide. We can see the overall brain metabolic level decreased to approximately 80% of the normal value. Of course, this patient did not recover finally. This is another job published in CNJ 2017. We used the DTI sequence scanning, select the relevant regions of interest, including brainstem, subcortical, and thalamus, and calculate the FA value and MD value. FA value means the fracture anisotrophy value. MD means the mean diffusive value. This all math and statistics. A statistical correlation was found with the coma recovery, the CRSR score, especially in the thalamus. The resting state functional MR and the DMN, default mode network, are now very hot technologies and issues of research. The DMN is considered to be the spontaneous intrinsic activity of the brain. So it has led to a lot of research on the endogenous activity of the brain. So we can see that from this paper, the VS patient actually, it likes like a plant, but the patient has very plant brain activity. But we used to use some special methods to detect them. As similar result, we found the central thalamus was the key area of the brain network of consciousness and the DMN. Okay, task function MR is another interesting research, such as the famous Owens report. This TBI patient was asked to imagine herself playing tennis and walking through her room. At the same time, a function MR scan was performed. Sustained activation of supplementary motor cortex was found when the patient imagined playing tennis, and the parahippocampal gyrus showed activation when imagining walking through her room. So the same research team examined another 54 patients. 5 patients were found responded to the instructions. So very interesting phenomenon. We also give the task functional MR test to this DOC patient. When we use the relative collimation, the visual cortex and the frontal signal activation can be detected simultaneously. So it's really interesting. It may elicit that the visual and emotional response through the cortical pathways. The auditory may have the brain function integrations with the visual and emotional response in DOC patient like this. And we combined the structural and functional MRI scanning for the prognosis analysis. The result showed the functional activation was closely related to prognosis. So this is like a math and the statistic analysis of the MRI imaging. Also, we use the machine learning methods to add clinical characteristics from the functional MR algorithm to obtain a more accurate predictive model. So it's not perfect yet, but we still use it as a reference. Another important method of DOC function is the EEG, and the ERP EEG means event-related potential EEG. For instance, the classical mismatch negative MMN components. MMN is like a local global task. It's a task EEG test. It is like we give the patient some voice like d d d do and d d d d, which means the odd and the standard. So we use the odd signals to minus the standard signals. We get the MMN waves and the data. So MMN reflects the automatic processing of the brain in an unconscious state. No need for the patient to pay attention to target during detection, but modulated by attention. So it's very classical. In the DOC patients, the MMN waveform also showed some special characters. It's not the same as the health one. We had studied a long time follow-up at 6 DOC patients, including intracranial hemorrhage, TBI, and cerebral infarction. Finally, 3 of these 6 patients got improvements of consciousness with MMN positive result. The MMN of ERP EEG test results were positive, which had a certain correlation with the improvement of the consciousness state of DOC patient during the rehabilitation process. This is an excellent job from Shanghai. They used the EEG method to assess the depth of language processing in DOC patients. Professor Xu Bin must be very familiar with this. It is your hospital's achievement. The results showed statistically different activations of DEG were found between MCS, UWS, and normal subjects when performing different semantic processing auditory tasks. Yeah, so it indicated that in the brain function of patients with DOC, there's an overlap phenomenon of language function and the level of consciousness. That's very interesting. But we all know that language and consciousness, they are in the different level. But in this paper, EEG finding that maybe when the consciousness become better and the language integration, the process may be initiated together. This is another paper. They found DOC patients showed classical EEG responses to their own name compared with others' name. So the results indicate that the own name may raise more active conscious processing. How to explain this? I think most of the data and result may be the philosophy of himself and the others. This is a review of DOC clinical EEG examinations in 2021. The EEG clinical detection methods are divided into 4 types now. For the resting state EEG, we usually use the spectral power, nuclear dynamics, and to analyze the connectivity and the networks. Another is sleep EEG. We evaluate the rhythm of the patient. And the ERP and the BCI, I have just mentioned before. And the TMS EEG is also a very good method, but it needs some special equipment. Actually, all of these have advantages and disadvantages. We still have a lot of research work to do in this field. Functional near-infrared spectroscopy means FNIRS is another potential clinical method. It is like a bedside function MR, but with much lower spatial resolutions. The equipment is portable, bedside, and low cost. It can also be used for some special patients as infants. So while the function of DOC is detected by all these methods and techniques, the next key problem is the treatment. In all kinds of treatments, neuromodulation is the most important. The whole therapeutic strategy is like comprehensive cocktail therapy. The key issue is to apply the right neuromodulation therapy to the right patient. We can use all of these methods. This is the famous report of the DBS treatment for the first DOC patient published in Nature. We can clearly find the correlation of the stimulation and rehabilitation. Of all the neuromodulation surgery options, we usually choose DBS, SCS, and vagus nerve stimulation, VNS. In our center, we have not begun to use ECS. DBS is mostly for the patient with relatively good structure of thalamus. SCS becomes more and more useful in many patients. VNS may be used especially for pediatric and seizure. After the surgery of stimulator implanting, the job is only 50% completed. The post-operative program therapy and the parameter adjustment are equally important, including the stimulation mode, intermittent or continuous, stimulus parameters choice, the frequency, pulse width, voltage, and interval length. This roadmap represents the current major clinical research ideas for neuromodulation in DOC. For example, we give the patient intervention, and during the follow-up, attention was paid to some clinical scale scores, adjustment of programmed parameters, improvement of neuroimaging, and changes of electrical, physiological indicators. This is the selection of screening of program control paradigm in SCS. We use the evoked potential as indicator of this stimulation. The change and after and before the stimulation is very obvious. Another very promising area in DOC is BCI, brain-computer interfaces. The BCI look beautiful. In fact, there's still a lot of work to be done in this area. The most important thing is the decoding of the signals. The signals, whether they are from EEG or from EMG. Advances in robotic exoskeletons is more like a Hollywood movie. And various rehabilitation training machines have also provided technical support for the functional improvement of DOC patients in the later period. So till now, we still are very confused about the neuromodulation. The network of human brain is unknown to us all. We also touch the tip of the iceberg. For example, we give the network 1 point stimulation and get some good improvements clinically. But how this process working is still unknown. But we still have some hope and opportunities. As Dr. Schnake said, DOC is not a barren desert, and the detection of residual brain function in DOC is getting easier. Detections of consciousness in DOC found that the consciousness were almost unimpaired in some patients. Sometimes we can find the CMD patient when we treat the DOC patient. Advanced detection technologies, including active and passive function MR, EEG, TMS EEG, will be help in the diagnosis and the decision making. Advanced functional detection technologies have revolutionized our understanding of DOC. Although great progress has been made, the research on coma and DOC still lags far behind related something like anesthesia and sleep research. As the Science magazine says, there are 155 questions left unanswered, with the first 25 being the most important. For example, the biological basis of consciousness, why we need to sleep, how does general anesthesia work? All these areas are still in a gray box state. This is our hospital, and welcome to Beijing. So thank you.
Okay. Okay, Warlick, are you there? Thank you very much. Let's get the moderator in. Warlick, are you there? I'm sorry, she must have stepped away. Let's see here. Wan Li. I'm sorry about this, Doc. Okay. Okay, very good. Okay. We're going to open it up for comments or questions. Can you see the chat box, Long, Dr. Zhu? On the right, do you see any comments or questions?
Yes, I can see.
Okay.
I see.
Okay, does anybody have a comment or question for Dr. Zhu? Let's see, go through those. Okay. Okay, Ben, should I ask you again to ask the Chinese audience if they have any comments or questions on what Dr. Zhu said? Do you think that would work, Ben, or it's really not worth pursuing?
Yes, this I check. Is it any questions?
I just thought of that. I thought, well, why don't we try that and see if it works? Because I hate to shut the questions off if someone doesn't speak English. And we certainly could interpret it once they got to you.
I see a question for Professor Liu.
Go ahead. Okay. Oh, see, is Harshad here? Let's see here. There's a couple of questions there. The year, okay. So no comments or questions, Ben?
Actually, I think most of the neurosurgeons are not very familiar to this kind of topic, you know.
Oh, okay.
Yeah.
Okay, very good. Okay, well, thanks.
Thank you.
Dr.
Thank you
Zhu,
very
thank
much.
you very much
Yeah.
for coming and spending the
Zhilong.
time.
Yeah.
And thanks always Ben for putting all this together. And thanks James Liu, he's back. You know, one thing I didn't mention, Ben, we're gonna, James and Neurosurgical TV are gonna put a series together,
Mhm.
cerebral vascular, every 2 weeks, and I'll let you know about it. We need to get a Chinese translator. We got to try to
Okay.
think about trying to get the Chinese audience being able to ask questions. You know what I mean?
Yeah, yeah,
Because-
yeah.
Without speaking English,
Mhm.
because they
Mhm,
probably
mhm.
had questions today of James, but we don't have it set up. But we'll set it up in the future. So, okay, very good. Thank you, everybody, for coming. And we'll see you in 2
Okay.
weeks.
See you
Thanks,
in
Ben.
2 weeks.